Okay, fantastic. So in terms of what we want to do today, as you probably know from the registration form, we're here today to talk about the Health Equity Impact Assessment tool. And what we're hoping is by the end of the webinar today, you're going to have, sorry, I just realized I'm slightly backwards here, that you'll have a basic understanding of what health inequity and health equity is and what some of the barriers to accessing good health is for all. We're hoping that you'll be able to identify any relevant vulnerable groups who might be overlooked by services and programs and identify the unintentional consequences of the program or service. And we hope that you'll be able to develop practical strategies to mitigate any of those unintended consequences, both positive and negative. So what we're going to do today is go over health equity and why it's so important to health promotion. We're going to give you a bit of a background on the Health Equity Impact Assessment tool, and we're also going to go through a case study and give everyone a chance as a group to work through the tool, and then we're hoping that we will have time for questions at the end of the group. So at this point, I'm going to turn things over to Annie Peng. Annie is a Master's in Health Promotion candidate at the University of Toronto. She's here doing her practicum this semester with HC Link. I would quite frankly be completely lost without her, so I'm very pleased that not only she's here today, but that she's been working with us over the past few months on our strategies to implement the Health Equity Impact Assessment. And I'm going to turn it over to Annie to start going through the webinar.
Okay. Thank you, Andrea. All right. So perhaps it's appropriate. I just want to talk a little bit about myself. I have always had a long and abiding passion for health promotion, and I worked in many different sectors in research and evaluation and community development, and also in the service provision sector. However, the health equity impact tool is something that is new to me, so hopefully this will be a learning journey that we can go on together. So first of all, I hope everyone can see that we have just a little picture that talks about health burdens and access to barriers as hurdles. And this image really spoke to me because we all know that everybody wants health. Everybody wants to be healthy and live a long life. However, some of us can get there easier than others. That we see this image kind of represents that the person on the top is just running toward health at full speed, whereas some people might have burdens, carrying a rock represented, or the person at the bottom has a huge rock and is jumping over tons of hurdles. And you can imagine how difficult it would be for that person getting to the goal of health compared to the person above. And now we're just wanting to do a little bit of an exercise with you. First of all, first question is, what barriers do you think makes it more difficult for people to achieve good health?
So if everything works the way it's supposed to, you should all be able to go into the box on the left-hand side and type in the answers to that question. And if that doesn't seem to work, then you can type them in the chat box instead. So what are some of the barriers that you think make it more difficult for people to be healthy?
Mm-hmm. So some of the things that are coming up are low education, underemployment, income, health status, racialization, lack of social support, language barriers, marginalization, stress. Yeah.
We've got lots of people that have talked about education and income.
Lots of systemic barriers, yeah, cultural barriers.
Great. So I think, please feel free to keep typing. I think we'll move to the next question, which is what vulnerable or priority groups do you see that are most affected by some of those factors that we just named? I'm typing some of the questions into the note pages so they're easier to see, but I'm going to ask you to please pardon my terrible spelling.
So we have seniors, newcomers, youth, Aboriginal groups, francophones, women.
Lots of people saying immigrants and newcomers.
Yeah, single moms, refugees.
Great. Great, thank you so much for your answers, everybody.
All right, so that was wonderful, and I think it's apparent that we all can think of many, many groups who are vulnerable or marginalized, and we all have a pretty good understanding of what are barriers to health access. So this is where the HEIA tool comes in. It really can help us move us forward. It provides a quick and easy way for service providers to identify who are the vulnerable groups and who are not being reached by a service or program, and really target resources to those groups. It's really a tool that, the way I think about it, it helps us to brainstorm, help us to start the conversation around who are not being served, who is being negatively impacted by our programs, and help us think of ways to begin to address those barriers. So this tool can be used at the management or board level in terms of planning, so that they can embed equity in all stages of an agency's policy or protocol. It can also be useful for frontline staff, as I have worked in that sector. I know what it's like to see something that you feel is a gap in service or is a grouping need, and to go to your manager and not having the words to say or not having the evidence that you need to make your argument. So it can be really useful for frontline staff as well to capture the evidence that you see around inequitable access or gaps in the program, and bring that recommendation to your manager in a paper format, in a structured format. Yes, that doesn't matter. Okay, so next we're going to do a bit more brainstorming. I want to take a moment to explore the idea of equity and inequity. So we think of inequity in the area of health. We tend to think of two groups that have different health outcomes, such as type of disease they get or the length of their life. So in other words, their mortality and morbidity. However, does every health difference indicate an inequity? So we're going to go into, we have some questions for you to think. Do you think this is an inequity? According to 2010 Stats Canada report, people aged 20 to 34, so these are men aged 20 to 34, make up the largest percentage. So they make up 35% of adult males who smoke, while people aged 65 or older make up the smallest percentage, 15%. So is this a health inequity?
We're just going to give everyone a minute to vote. Yeah, I think I did.
Yeah. Oh. Okay, so this is, again, I created these, and feel free, we will love, for you to agree or disagree with my thoughts, but I would say no for this, because I interpret this as, number one, there are, it has to do with kind of maybe youth culture or work culture, that men who are younger take up smoking more, whereas men who are older tend to quit smoking or have various disease or illness that prevents them from continuing smoking. I would say no for that one. Okay. So the second one is, in 2009, the smoking rate is lowest in BC, so at 16%, and highest in Nunavut, so 61.3%. This is compared to the national average of 20%. Is this a health inequity? So, yeah, so I would say yes for this one. There is definitely an inequity issue happening there, and we'll go into that more later.
Oh, all right. Okay.
So the next one is the poorest 20% of Canada's population has more than double the chance of developing 2 or more chronic conditions such as heart disease and diabetes compared to the richest 20%. So is this a health inequity? Oh. Very clear voting here.
I forgot to broadcast. Sorry. There we go.
So I would say yes. I mean, it's again, we'll go into that later, but definitely I see that as an inequity there.
And our last question.
Okay. So, and the last one is nearly 1 in 5 adults from First Nations communities has been diagnosed with diabetes, while for the general population, it's 1 in 19. This is from the Heart and Stroke Foundation. So is this a health inequity? And again, it seems overwhelming that people are saying yes, it is, and that's what I had in mind as well. Okay, and just some more examples that we found that was just so compelling and so shocking that we felt it'd be good to share with you. So in Scotland, a difference of 16 kilometers in neighborhoods can result in a 28-year drop in life expectancy. This is talking about a study that looked at 2 families living in 2 different neighborhoods, just a 16-kilometer difference. The average lifespan is 28 years in difference. And the same thing we can see happening in Hamilton, done by another study, that they found a 20-year difference in life expectancy between a high-income neighborhood and low-income neighborhood. So this is, again, just next door to where I'm at in Toronto. And again, just to reiterate that, again, chronic conditions and income, clearly research has been shown over and over again is related, that the higher income individuals experience less risk for chronic conditions. And again, diabetes rates as well as other chronic disease rates has been seen consistently across Aboriginal populations, First Nations populations. And the last one that was not polled, but among youth living in the lowest income neighborhoods in Ontario, 37% of them report being overweight or obese, whereas compared to youth living in the highest income neighborhoods in Ontario, only 18% of them report the same condition. So perhaps through these exercises, you might have guessed that health inequity is more than just a noticeable difference between 2 groups of people. Margaret Whitehead's definition sums it up well. Health inequity or disparities are differences in health outcomes of a specific population that are systemic, patterned, unfair, unjust, and actionable, as opposed to random or randomly occurring or caused by those who become ill. So I just want to talk a bit more about what does that mean, because it's quite a mouthful and it's somewhat abstract. So systemic and patterned, what does that mean? It means that there's something about the system in our society that is producing and reproducing these differences, that they're not just random occurrences. Unfair and unjust, she also mentioned. These are differences that are not just mere misfortunes, so someone's being struck by lightning or injured in an earthquake, but these differences offend our sense of right and wrong. There's something wrong here that's not okay. And finally, actionable. These are something that we can do. We can do something about these differences. There are solutions. I should say, Andrea, please feel free to interrupt me if there are questions, because I'm not looking at the screen. And in case that didn't convince you already, there are other reasons to consider health equity. So cost saving. So if all Ontarians had the same, so rich and poor, all Ontarians have the same health status as Ontarians with higher income levels. A report estimated that 30% of the hospitalization from the four most common conditions, so that is heart failure, chronic obstructive pulmonary disease, diabetes, and asthma, those four chronic conditions, could be potentially alleviated or avoided. So we can eliminate 30% of our hospitalization, and that comes with incredible cost-saving implications. And also legal reasons. Some of you may be bound by the following legislature to consider equity in all aspects of your service delivery. So legislation that mentioned equity include Excellent Care for All Act in 2010 and the Local Health System Integration Act in 2006. So now we want to take a closer look at the HEIA tool, and I want to give you some background to it. So the HEIA tool was developed by the Ministry of Health and Long-Term Care in partnership with Local Health Integration Networks, or the LINs. It was derived from an already widely practiced tool called the Health Impact Assessment, often associated with environmental assessment context, to determine the potential effects of a project, such as perhaps a pipeline, on the health of a population. So other organizations are also beginning to integrate this tool into their planning and training process. So we have seen Public Health Ontario preparing a supplement guide to help health units implement this tool. This is available on their website. Center for Addiction and Mental Health, CAMH, and the Wellesley Institute have each developed multimedia training materials and resources on this topic. And so furthermore, we want to emphasize that the HEIA tool is a broad application that can be used by organizations and service providers in Ontario whose work has an impact on health. So therefore, this tool is not just meant for healthcare or people in public health agencies or in hospitals or the Ministry of Health and Long-Term Care, but it's also useful for sectors outside of the traditional health arena, so such as people in the Ministry of Education, in schools, child and youth services, or other community nonprofits. Again, given our understanding that health is conceived broadly, mental health, physical health, spiritual, social health. And finally, we just want to stress that the purpose of this tool is to reduce inequities that result from barriers to access and to improve positive health outcomes. Most specifically, it is used to identify unintended health outcomes of impact of a policy, program, or initiative on marginalized and vulnerable populations. This is important because it's different from a formal evaluation that looks at how your program deals out intended consequences. So it's looking at things that perhaps the program weren't intending, unintended consequences. And secondly, this tool helps us to look at both positive and negative consequences. So not just barriers or negative effects, but what are some positive things that came out of this program that weren't thought of or weren't intended. Who should use the HEIA tool? So the ministry really thought that it's preferably done by someone internal because of the level of knowledge that one would need to do this tool, knowledge of your staff, your work culture, your organizational history, and this tool is highly reflexive in nature. So it really requires an organization to sit down and think about how their work is impacting. So it's preferably done by someone internal, not necessary to hire an external consultant. And how much time does this tool take? So it is really scalable depending on your needs and depending on how much time you have. It can be done as a desktop assessment, so using resources, information you already have. I know most agencies collect some kind of stats, have some kind of reports. It can be implemented in a staff meeting, talking to other staff about what kind of barriers they see. I know we had done a mock one that took us half an hour. Or it can be done as a rapid assessment, so more in-depth, more detail, involves perhaps some outreach. Your client population, perhaps doing a quick survey, might take a few weeks. And finally, you can do a really comprehensive assessment involving more extensive research and extensive community consultation. This could take upwards of a few months. And when should an HEIA happen? So before me, this is kind of a diagram of the illustration of the cyclical nature of program development. So you have needs assessment, determining your objectives, and you have research and analysis. I'm not sure if people can see my mouse pointer, but
no.
Oh, okay. That's fine. We have number 2 is the research. You do some research. Number 3, you recommend options. Number 4, you implement your program of service. Oh, thank you. Number 5, you review or reassess. So HEIA can happen, preferably would happen prospectively in the planning, researching, thinking stage to think about how you're going to eliminate barriers to access. However, it can also be done retrospectively. So at the end to kind of review your program, to think about program expansion, service realignment, or stoppage, incorporating it into an evaluation component. And the good thing to mention is that this tool is a living document that evolves throughout the development and planning process. So it's really something that's not meant to be written in stone.
Okay, so now that you've heard about the HEIA tool and a little bit of background about health equity and why the tool was developed, I thought we'd actually take a little bit of time to go through it step by step, and then we're going to do a case study where everyone will actually get a chance to work through the tool. We'll work through it as a big group, and we'll see how that goes. While I'm going through the HEIA tool, if you haven't already had a chance, you might want to go to, I'm going to attempt to use my pointer here, to the Files box, which is on the right-hand side of your screen, and you'll see 2 files in that box which you can download. There's today's presentation, and then there's the case study. So if you haven't already opened that document, you might want to have that handy. I will have it open on the screen, but sometimes, oh look, there's my pointer. Ooh, wow. There we go. You might want to have that handy just in case. Okay, so the HEIA tool is in 5 steps, and the first step of that is scoping. And in the scoping step, it's a chance to really think about who are the folks that are going to be most vulnerable or most marginalized by the program, the initiative, the strategy, or the policy that you're taking a look at. In the tool, which I appreciate it's hard to read on the screen, but hopefully you've downloaded that file and you'll be able to read it a little bit better, we actually have a list of some of the populations. And what's important to say is that it's a pretty big list, and it's not expected that you actually go through every single group for every single program or initiative you're using the tool on. The first thing that you want to do is take a look, really think about who are the folks that are most likely to have difficulty in accessing your program or in receiving the benefit of your service, and those are the folks that you want to consider as you move forward. One really important thing to say is that it's very easy to silo people in boxes and to say, oh, well, someone is homeless, someone has a mental illness, someone is a woman, someone is low income. And sometimes we forget that a lot of those factors can really commingle, and someone can be a newcomer to Canada with a low income and a low education and experiencing food insecurity all at the same time. So just a note to say that while we do need to think about population groups, to remember that there's going to be a little bit of mixing between some of those groups. Once you've had a chance to think about the populations that could be affected by your initiative or program, the next step is to think about the unintended impacts. So when you're doing the HEIA tool, it's really not meant to reinforce the objectives of your program. For instance, if you have a good food box program you want to use this HEIA tool in, and the objective is the program to increase consumption of fruits and vegetables, we don't want to take a look at that. It's not a tool designed to help you determine if your program is going to be effective in terms of meeting its objectives. It's a tool designed to help you think about the unintended impacts. So if your intention is to increase access to vegetables and fruits, what are some of the other things that could happen that are both positive and negative? Step 3 is one of my favorites, and it might be because the word mitigation is one of my favorite words right now. And in Step 3, we think about, okay, if these are the folks that could be affected by our program or initiative, and these are some of the positive and negative unintended consequences, what can we do before we launch the program, before we implement the policy, to help mitigate some of those effects? So some of the common barriers that people experience in accessing programs and services might be transportation if you're in a rural environment. So what are some of the things that you can do before you launch your program to help folks who might be affected by transportation issues to get to your program? One of the other important things in that mitigation step is to be very practical. Often when we're working in these types of situations, we can get in sort of a brainstorming or a blue sky mode. But when we're talking about mitigating factors here for folks to access our programs and services, we do want to be very practical. And we also need to keep our timelines in consideration. Okay, sorry, a little bit of flipping of pages there. In Step 4, we take a minute to, or some time to monitor the actual program or the service. So what you're doing within this step is taking a look at, did your strategy, did your program, your initiative actually happen? Was it effective? And then take a minute to actually find out if some of the barriers that you foresaw were actually barriers. Did the mitigating steps that you put in place, did that actually mitigate? Was there anything else that was unintended that happened as a reaction or as a result of your program or your service? And some of the ways that you can do that are by using client satisfaction surveys, by doing community engagement and monitoring outreach activities. And again, as Annie said, that this HEIA tool is really meant to be a bit of a living document. So you can, as your program continues, you can continue coming back to the HEIA tool and taking a look at how your program or your strategy actually was implemented and what happened. I know that the Ministry of Health and Long-Term Care, who developed this tool, they get really excited about the dissemination step. When they first developed this tool, it was only 4 steps, and they put the 5th one in, I think for a couple of different reasons. One is it's important for organizations who use the tool to tell people that they use the tool and share some information about their results. There isn't currently a database or a listing of folks who are doing health equity impact assessments. So when we're trying to compile case studies, we don't really have a sense of where to go. So if those of you who are on the line today, if you find yourself in the future using the Health Equity Impact Assessment tool, I'd encourage you to let us know and or let the ministry know so that they can kind of have a sense of who's using the tool and how it's going. The other really important thing is that it can be a bit of a communications tool for you. Some of your organizations may have mandates or strategic priorities around health equity, and so you may actually want to write in that you're using the Health Equity Impact Assessment. You may want to be broadcasting on your website or talking in meetings with partners about the fact that you use this tool and this is how it informs your program. These were the results that we achieved not only through our program but as a result of using the HEIA. Okay, so we're going to go through a little bit of a case study. I'm just looking in the chat box. It doesn't look like we have too much activity going on there, so I would encourage you all to chat box if you have questions. Sorry?
I'll monitor.
Oh, Annie's going to monitor. Perfect. Okay, so I'm bringing up the case study on the screen. However, it's going to be pretty challenging for everyone to read, so hopefully you've had a chance to either print out or have the document open on your screen. And I'm just going to put Annie on the spot and ask her to give us just a very quick overview of this case study, and then I'll walk us through each of the steps.
Sure. So I think it's okay to say that this is a program that I kind of somewhat made up. However, we made it as realistic as possible. And so it's a food security based program that I thought of, called it Veggies Unlimited. And basically, did you want me to go through
really quickly?
Okay. Basically, it is a food distribution program, kind of like Food Share, borrow some ideas from Food Share. And this supposed program is going to be implemented in Hamilton. However, there might be some areas, some glitches there that we're hoping that you can look through and help us to identify what are the barriers and who are the target groups who are either going to benefit or miss out in this program.
Okay, so we're going to take a look at, I'm just going to go back to the tool here, and keeping that case study in mind, and hopefully you've had a chance to read it a little bit, we're going to go through the different steps in the HEIA tool, and we're going to start with step 1, scoping. So in taking a look at the profile of the organization of Hamilton and the description of the program, what are some of the audiences or some of the populations that you think we need to consider when we're looking at this program? So we have a suggestion that low income, folks with low incomes, are one group that we'll want to take a look at. Folks who are using homeless shelters. Got a couple people talking about the homeless, that's great. People with disabilities, non-English speaking residents, those in rural and remote. While Hamilton is a big city, there's lots of smaller communities that surround it. Seniors, Ontarians with disabilities. Single parents, those with language barriers. Wow, lots of folks. So for the purpose of going through this tool, we're just going to select one population group. Again, when you're doing this tool, using it in your own program, you'll want to take a look at the populations that you think will be most effective for your program, and you may need to prioritize a little bit. It's going to be difficult to do this tool for 20 different population groups. For the purpose of today, we've got a little bit of feedback happening, so if everyone can please make sure that your lines are muted with *6, please. And Annie, do you have a population group you'd like to recommend that we take a look at?
Sure. Why don't we let's do new immigrants new immigrants with limited mobility, so maybe new immigrant seniors with limited mobility.
New immigrant seniors, fantastic. So let's take a look at, as also part of our scoping exercise, some of the determinant of health that are going to affect seniors with low mobility? Or is it low
new immigrant seniors.
New immigrant seniors. Okay. Okay, so those with limited transportation, absolutely. Those affected with differences in language, health issues, those experiencing racialization, yep.
Caregivers.
Yeah. Low income, and it does sound like we do have someone who is not muted, so again, please *6. Right, so we'll let people keep typing, and keeping in mind some of those social determinants of health, let's think about some of the unintended impacts, both positive and negative. So what I'm going to ask you guys to do is you type these into the chat box. If you can either put a plus or a minus sign. So plus for a positive impact, minus sign for a negative impact. So what are some of the unintended impacts that you think would affect these, this population that we're looking at, newcomer seniors? Oh, that's great. Yes. Positive impact. Socialization. So when seniors are coming to the center to pick up their foods, then there's an opportunity for them to meet other people and talk with them. Yeah, definitely this is a mitigating strategy, Torshi, that we need to take a look at, is making sure that there are culturally appropriate foods for the groups that we're taking a look at. Differential access. Hal, I might ask you to talk a little bit about what you mean by differential access. Is that just in difficulty in actually getting to the physical location? Hal, you can either speak by unmuting your phone at *6 or you can type into the box. Okay, Chantal has a really good point because the program locations are in church basements, so there could be some mobility issues. Again, we've got someone mentioning socialization, culturally appropriate foods, another positive effect of community support. That's great. Great. So Stephanie has a great mitigating strategy about having flyers in other languages, different modes of communication, on-site interpreters. That's a fantastic strategy, Stephanie, once we hop into step 3. And it looks like we've moved right on to mitigating strategies, because Lizanne has also suggested providing transportation to locations. Oh, Natalie reminding us that while it is a low-cost program, there still may be financial barriers. Lara, a great point that some folks may be unfamiliar with some of the food in the box, so while they actually receive it, they might not actually use that food. Great. So let's move on to mitigating strategies, and please do feel free to keep typing in those potential impacts into the chat box. But we'll go on to some mitigating strategies. So again, we had some suggestions about language, making flyers available in different languages, having folks on site who could speak different languages. We had someone who suggested providing transportation or perhaps alternately a delivery service. Oh, Stephanie, that's a great suggestion. Wheeled carts. Boxes can be heavy. Yes. Fantastic. Any other mitigating strategies folks can think about or think of? Got a great suggestion from Hal on a bit of a buddy system. What I really like about that is that a lot of people talked about the unintended impact of socialization and social opportunities, so that could really build on that. And Trish has another great strategy there too of a volunteer delivery program, which could also offer opportunities for friendly visiting. Lizanne has a great suggestion to provide recipes with some of the ingredients in the box that may be unfamiliar. And of course, we need to consider language and literacy in that. Oh, food demos, cooking classes, fantastic. Lots of suggestions about cooking classes, community kitchens. Yep. So one thing that hasn't come up, and it could be because our population group is seniors, is that the hours of the program being 9 to 5. And we might have made a bit of an assumption there that because it's a senior population that those hours might not be a barrier. But we might need to consider that for other groups who want to access the program.
Just want to, it kind of reminds me of a lot of immigrant seniors that I have seen provide childcare for children while their adult children are working outside. And so it could be, perhaps I tend to assume, you'll be at home all the time, but they might be very busy providing childcare.
Mm-hmm. Okay, so please do feel free to keep typing in some mitigation strategies. We're going to go on to step 4, which is monitoring. So again, keeping in mind our specific population group of newcomer seniors, how can we check in with this group to find out how this program is meeting their needs, and if we have taken, if the things that we have considered in terms of our mitigating strategies are actually being successful. So just as an example, we might want to consider things like questionnaires or focus groups, just to kind of give you an idea of what some of those tools could be. But what do folks think? Oh, wait times, self-assessments, focus groups, which again would give folks an opportunity for socialization and increased social exposure.
Telephone chain.
Yeah, that's an interesting idea, Judy, in Windsor, about a telephone chain. Hal's suggestion is to do a little bit of random sampling and keep an eye on how they are accessing the program and using the food. Targeted home visits. I love how you're thinking, Stephanie. I hope you'll fund this program. And Jennifer reminding us of one of the quintessential health promotion approaches, which is talk to people, for Pete's sake, and just get to know them, find out how they're accessing the program, find out if they're experiencing barriers that you didn't anticipate, etc. Okay, so again, feel free to keep typing in the box for step 4 monitoring, but we will move on to step 5, which is dissemination. So keeping in mind our organization, so Veggies Unlimited, what are some of the things that Veggies Unlimited could do to disseminate the findings of their HEIA assessment and how the program is going? Oh, great suggestion from Chantal of reporting to municipal council. We did a little bit of a focus group on the HEIA tool a few weeks ago. One of the things that we heard from folks is that the HEIA tool could be an advocacy tool, as you're suggesting, Chantal. It could be used to advocate to municipal council. It might be used within your own organization to let people know about some of the impacts of health inequities on folks trying to access their program. Hal suggested identifying key partners and providers for this population and let them know what's happening. So do a bit of a communication strategy with some key stakeholders. Marty Paul, oh hey Marty, suggesting a media release. Sharing results with users is really important, particularly if you're distributing questionnaires or having people engaged in focus groups. Always really important to follow up with folks and let them know how their participation made a difference. Stephanie's suggesting presentations at church groups, especially since this program is being hosted in churches. That would be a really important group to communicate with. Torshi reminding us that newsletters should be available in multiple languages. They could be distributed with the food boxes or with the food. Great suggestions. sharing with our own Board of Health or with our organizations and funding partners. Oh, yeah, that's a really interesting idea, Judy, about publishing local stories in business magazines. So that's a community, a stakeholder group that we often don't pay a whole lot of attention to. So I really like that suggestion. Great ideas coming in. Oh, yeah, Marty, that's a great suggestion, kind of building on that business community idea of presenting findings at the Chamber of Commerce. Fantastic. All right, so I recognize that this has been a little bit of a whirlwind trip through the HEIA tool. So I think I just want to recap a couple of things, and then we're going to open up the phone lines and the chat boxes for folks who have experiences that they want to share or questions that they want to ask. So I'm just going to pop back to our PowerPoint presentation here for a second. Okay, so one of the things that that I hear from folks a lot with impact assessments in general is that people are really uncertain how much time it's going to take and who should be involved. And we did cover this a little bit in the presentation, but I just want to pull a couple of things out. One of them is that one of the great things about this particular HEIA tool is that it was really developed to be done by you, by the folks who are involved in the program, the initiative, the policy. It's meant to be something that you can do yourself off of the side of your desk or in a with folks who are also involved in the program. It's not meant to be something that you have to hire a consultant and do a great big report on. That may be the road that you want to go down, but this particular HEIA tool is meant to be something that you can do yourself fairly quickly and easily. To that end, there may be some limitations in terms of how comprehensive you can be, how much research you can do, how much input you can gather. So when you're making the decision about doing an impact assessment, you'll want to consider how much information do you need? What really is it that you're trying to achieve, or what kinds of information are you trying to gather? And that will help you decide if this particular HEIA tool is the tool that is going to best meet your needs. I am also going to say that HC Link is available to help folks out. If you want to do a health equity impact assessment on a program, service, or initiative in your organization, and you need someone to brainstorm in terms of process or help you out, please feel free to contact us anytime, and I will go over our contact information before we end the call. So what I'm going to give folks an opportunity to do now is either ask questions or maybe tell us a little bit about an experience that you have or make a general comment. That either by unmuting your phone using *6 or you can type in the chat box. So we'll just give folks a few minutes to participate with comments, questions, or experiences. It does sound like we have a few people who are not muted, so if you're not planning on speaking up, please do mute your phone. Otherwise, you can unmute and speak. We might start with a great question that Hal's typed into the box. How would you manage expectations, especially with programs that supply existing needs such as food, but can't sustain that level of support over time? Can you, in effect, create a new inequity? I think that's really important. And one of the things that we talked about is really needing to keep this assessment practical and real. Sometimes by doing something like the HEIA tool, which encourages us to look at all sorts of different population groups, all of a sudden our program can really explode, and we can start to create something that goes beyond our capacity. Also, when we're thinking about doing focus groups or questionnaires or talking with folks, we can sometimes build in an expectation without even meaning to. The program is going to expand or continue or be even bigger than it is at that point. So I think that's really important to balance. And I would suggest that how you need to consider that right from the beginning when you're doing the HEIA tool, when you're sitting down to do the scoping exercise, to really consider your capacity as part of this assessment and have that really be kept real as you're going through the tool. Do you have anything to add to that, Annie?
No, I think that's great. And being in research, I can concur with that. That a lot of times you really need to make it clear when you're doing any kind of research where you're asking input from your clients to make sure they understand that they're not going to maybe benefit in terms of their services. They're not going to benefit by participating in your study, or that this program isn't going to expand just because you're asking about people's feedback. Just make your expectations very, very transparent to people.
So we have a question from Chantal about whether we should complete a separate HEIA for each population group. That's a great question. It's a little bit difficult to see with the tool, the template itself, which is really a chart on one page, that I think it really comes down more to preference, whether you want to just fill in the tool for one population at a time, or whether you want to try and do multiple groups on one tool, or whether you want to fill in multiple templates for each population. I think that's really more personal preference than anything. Lara has a great point that I just want to address really quickly, which is just about the plethora of tools that are out there to help us plan and evaluate and strategize and do all of these great things. And just to remember that we need to still do things well. And I think that's a really great point, Lara, that just because there are 14 tools out there doesn't mean we need to do them all. We need to really make strategic decisions, again going back to our capacity about what we can do and what we can do well. Stephanie's got a comment about, oh, interesting, evaluating a food bank at her church, which is supported by a local synagogue. That sounds like a great program. And we would love to help you out with that. If you need any support with that, Stephanie, you can give us a call, and I'll give our contact information shortly. Jennifer raises a really great point, and I'm going to use the term sensitivity training in quotation marks, just to remind us that we're out there doing assessments, working with communities, that we might need to go through some training or some self-assessments to make sure that we're unintentionally generating more inequities through the work that we're doing. That's a really great point. Are there any other comments, questions? Has anyone done a health equity impact assessment or a similar type of assessment that maybe wanted to share some of their experiences? You can either unmute at *6 or type in the chat box. Shelley has a question about evaluation. Shelley, that's a great question. We're going to have to check with the ministry on that. To my knowledge, they haven't evaluated the tool at this point, and it's certainly something that we're encouraging them to do. There's also, as Annie mentioned, a number of organizations that are supporting the implementation of this tool. There's Public Health Ontario, CAMH, and the Wellesley Institute. And actually today, as we speak, that group of people is actually meeting to talk about their experiences in supporting folks with the tool. And Peggy from Health Nexus and HC Link is at that meeting because we're a little busy delivering this webinar. And I know that she will ask that question. So hopefully we'll have an answer for you on that at some point. Making sure I'm not missing any comments in the chat box. Stephanie has a great suggestion about having multiple people complete the assessment from a range of folks, from participants to organizers to other community members. It's a great suggestion. Yep, a 360 type. HAL is actually conducting an assessment right now with a program that's empowering marginalized youth. I'd love to hear about that sometime, HAL. Okay, so I might just go on and let people continue typing any questions in the box that they have. I just wanted to point out to people again our website, hclinkontario.ca. I mentioned a few times that we're available to support folks as they're implementing the HEIA tool, and of course we can provide support on a number of different topics and types of areas. We can either come on site to you, or we can work with you and your partners over the phone or via email. So even sometime if you just have a simple question, if you just want to pick someone's brain for 15 minutes or do a little bit of brainstorming, please feel free to fill out a service request form on our website. You can also call. Do I have the number here? Oh, okay. You can also give us a call toll-free or a local Toronto number, and we can certainly help you out as much as we can. We also have just a couple of, or a few different resources here. And again, if you've downloaded the PowerPoint presentation, you'll have links. Velma was asking earlier about the link to actually download the workbook and the template, and the link is here. If you Google HEIA tool, it should be the first one that comes up. The ministry is very proud that they're the first one to come up, so you can always Google that as well. And as we mentioned, the Wellesley Institute, Public Health Ontario, and CAMH have some tools as well. And the National Collaborating Centre for Methods and Tools also has some great resources on how to conduct an HEIA, which are also super helpful. So I'm going to close in just a second, and I'm going to ask folks, I'm going to be posting a link to our Survey Monkey evaluation form so that we can get your thoughts and your feedback on this webinar. I know that Annie, as a student, will really appreciate that, but just from a broader perspective as HC Link, we really love to know how helpful you found the webinar and or what we could do to improve. I'm also really anxious to hear, in particular, how folks felt about the case study and going through the steps of the tool using the chat box. So when you're filling out the evaluation form, if you wouldn't mind giving a little bit of feedback as to whether or not you found that to be effective. Oh, and Jennifer wants to become more involved. Yeah, please contact us, Jennifer, and we would happily figure out how we can do that. There's also a question about, will we get the presentation slides again? You can download them in the box right above the chat box called Files. You will see the presentation, which you can click on and download. We'll also be posting the slides and the link to the recording on our website. And is there a way to capture our responses during the case study? It would be helpful for orienting others using the tool. Stephanie, yes, it will be available. The chat box is available in the recording. But we're also going to be doing a resource. Annie and one of our other students is going to be writing a resource, and we'll try to incorporate some of your results right into that resource. So right before I close, I'm just going to mention we're going to be posting something up on our blog. If you just go to our website, hclinkontario.ca, and on the right-hand side, you'll see our blog. We'll get something posted up there within an hour, and then you can comment on it. You can either ask a question, you can give us your perspective or your thoughts, or maybe some concerns you'd have about doing the HEIA tool, and then we can get a little bit of a conversation going between folks. Just to let you know, if you do comment on the blog post, there'll be a little bit of a delay as we do moderate comments, but we do have someone standing by to do that. So once you hit the post comment and you don't see it on the website, don't panic. It will go up as soon as the post is moderated. Oh, Stephanie, aren't you fabulous? One of the best webinars ever. That's great. So thank you everyone so much.
Thank you so much.
I'm just going to close the meeting and post. When I close the meeting, we'll have the link to the SurveyMonkey posted. You'll also receive that via email. Thanks everyone so much for being here, and I look forward to hearing from you all if we can help you in any way, and your comments on our blog post. Thanks everyone.